Okay, good evening once again. So the title for the tutorial this evening is Tibia Fractures, Proximal and Shaft. So there's two parts. We're first going to talk about tibial plateau fractures. I'll just first give a overview, and then we'll look at some cases. And then secondly, we look a little bit at sort of controversy in the management of tibia shaft fractures, because the basics is probably below your guys' level. So we will try to look at the correct aims of treatment when it comes to tibial plateau fractures, how to identify associated injuries and which ones need treatment, and to learn some of the non-standard approaches, to have an approach to the common fracture patterns, and to identify and adequately treat the unusual fracture patterns. So tibial plateau fractures really have got two subgroups. It's the younger, higher energy injuries, and then the older insufficiency fractures. And the mechanism is mainly a combination of an axial load with a varus or a valgus force. And important to note here that it carries a relatively good prognosis when it comes to intra-articular fractures. And we'll talk a little bit about that, more about that later on. So the most common associated fracture of a tibial plateau fracture is a meniscal injury, and this occurs in up to 30% of Schatzker 1 and 2 injuries. So that's why you should always have a strategy here to assess for a meniscal injury. Of ligamentous injuries, the ACL injury is the most common, and other associated injuries is also patellar tendon avulsions or other fractures around the knee, including patellar fractures, distal femur fractures. So this is a paper that made everyone worry, where they looked at MRI scans of every tibial plateau fracture, looking for associated injuries, and the surgeons here said that they changed their approach after looking at the MRI scan in 23% of cases. So when I was a reg, Prof. Roche was always worried that we were missing lots of associated injuries that needs to be addressed by not MRIing tibial plateau fractures. If you closer look at this paper, that it wasn't a series where they MRI'd every plateau fracture. They really just looked at a series of MRIs done for tibial plateau fractures. So obviously these were cases where there was already a high suspicion of some associated soft tissue injury that might need treatment. So from the same center, both in 2018, they looked at 82 consecutive tibial plateau fractures, and all the patients had an MRI scan at presentation. They were treated according to the standard protocols at the unit, and they looked at the clinical outcome at 12 months. And they found in this series, interesting, that 73% of tibial plateau fractures had an associated soft tissue injury that you can identify on an MRI scan, although it in almost all the cases didn't alter the surgical plan or the outcome. So that was more reassuring. And with the soft tissue injuries associated with the tibial plateau fracture, especially the ligamentous injuries, you mostly don't have to address that with the initial injury, except for meniscal injuries. So the classification we all know for tibial plateau fracture is the Schatzker classification. The Schatzker classification classifies what I call the usual fracture patterns. This is one of the classifications that I would say, even if there were better ones available, it's so embedded in clinical care, all around the world, that it's a useful classification, that it's quite reproducible, and it helps us to communicate, even though all fractures can't be classified using the Schatzker classification. So the Hollenmoor classification is not a classification that I would, think one needs to know all the subtypes, but you need to know the specific ones where that's not really classifiable by the Schatzker classification, as in the Holland-Moore type 1 and type 2 injuries. So the ideal classification would probably be a combination of the two, although, like I said, the Schatzker classification is so embedded in our clinical use that it's the one that I would stick to, except for the injuries that do not fit into the Schatzker classification. So the initial management of plateau fractures is always debate whether one needs to applying a spanning X-fix. Now, just like in polytraumatized patients, whether for your exam or in real life, you should always be concerned about managing systemic injuries first. So it's good always to mention that you'll treat the patient according to ATLS principles. With fractures in the lower limb, specifically out the knee and distal tibia, like tibial plateau fractures, it's always good to say that your management would be dictated by the degree of soft tissue injury. Not every tibial plateau fracture needs a spanning X-fix, but any case of significant shortening, specifically ones where your definitive management is going to be plating, it's very difficult to get length back, even after a few days or a week down the line. Any case of a severe soft tissue injury or any polytrauma patient where it's difficult to nurse with a cast in ICU, although I would say that's a relative indication. But definitely any, especially bicondylar fracture with significant shortening where your definitive management is going to be a plate, you need to X-fix. In certain cases, especially a case where that you need to definitively treat with a circular X-fix, there's not a lot of shortening and you're going to get to that patient in a fairly short time frame, then it's not always necessary to do a spanning X-fix. Additional imaging, while CT is the sort of gold standard for all displaced intra-articular fractures, of course, as you have more experience, it's not necessary to CT every single case. As I would say with any intra-articular fracture, if you can look at the X-ray and basically draw an axial cut in your mind, of course, you understand the fracture pattern, but specifically in the exam, when you're more junior, you should always mention that you would consider a CT scan. Many of you might end up working in an environment where the CT for every displaced intra-articular fracture is not available, and you need to select the ones that really benefit from it. And in plateau fractures, oblique views can be very helpful. So if you don't have access to a CT scan for every single case, and you can do oblique views. Oblique views also very useful in theatre to look for your screw length at the end, and also to look whether you've reduced the plateau adequately. I'm sure all of you have experienced that you're very happy with your intraoperative C-arm image in a plateau fracture, and then you look at the post-op formal X-ray and it doesn't look the same, and you're very disappointed. And that's obviously because in this, the image is not taken in the exact same way. So always a good practice with plateau fracture or lots of intra-articular fractures is to do oblique views in theatre. If you do an external oblique, you can visualize the posterior medial aspect of the tibial plateau, and if you do an internal oblique, you can visualize the posterior lateral aspect and anteromedial on the other side that might be obscured by overlap. The plateau view is also useful. You'll know from your anatomy that there's a 9-degree posterior slope in the proximal tibia. So in other words, in a perfect AP, you're not looking straight down the joint. So by tilting the beam 10 degrees, you can look straight down the joint. MRI scan, I would say, is very rarely necessary in tibial plateau fractures. The place for an MRI, I would like to say there's multi-ligament knees that's associated with a fracture. These are usually small rim avulsions or maybe even small depression fractures. These are the cases that need an MRI scan. High energy tibial plateau fractures like Schatzker 5 and 6s or Hollenworth fractures with large fragments. These are more bony injuries. There might be associated ligamentous injuries, but these very rarely needs to be addressed. So an MRI scan is seldom indicated. So what are the aims of treatment? Well, the first aim of treatment is to maintain a sepsis-free soft tissue envelope around the knee, to restore the joint stability. And here we're not talking about necessarily reconstructing ligamentous of soft tissue injuries, restoring joint stability by restoring the rim, so the articular rim. In other words, that there's no bony instability by the femoral condyle falling into a depression, because either the rim is displaced or there's a big depression. To maintain mechanical alignment within 5 degrees, and to identify and treat associated injuries. And as we say, specifically meniscal injuries. So meniscal injuries are important to identify because they are associated with a poor outcome if not addressed. So what are the indications for surgery? Well, the indications for surgery is a mechanical axis deviation of more than 5 degrees. Well, this is a rim depression large enough that will affect the mechanical axis more than 5 degrees. Condylar widening. There's no consensus in the literature of the exact amount of condylar widening that's acceptable. Some authors say 5, some authors say 10 millimeters, but definitely condylar widening of 10 and more is an indication for surgery. Same with articular displacement. There's various recommendations. 2 millimeters are mentioned by some. I think for the Plateau, 2 millimeters, you can tolerate a bigger articular step than 2 millimeters. And most authors use 5 millimeters for the tibial plateau. It also depends where the depression is. If there's a stable rim, but there's a sort of central small depression of more than 2, but even up to 5 millimeters, that's not necessarily going to affect the outcome of the injury, because it won't affect the stable range of motion of the joint. And then again, various of valgus instability, like I said, mainly due to depression of the rim of the plateau, and not so much because of associated ligamentous injury. Some mention in the literature that all medial condylar fractures should be fixed. I agree that most do. Never say never in orthopedics. There are the odd cases where medial condylar fractures are completely undisplaced, and we've certainly treated them non-operatively successfully by just watching them closely. The same with bicondylar fractures. So I'd say most bicondylar fractures, almost all, needs surgical fixation, but there's odd cases, especially in the osteoporotic fracture patterns, where there's sort of it's more of a crush in osteopenic bone, and occasionally these cases can be treated non-operatively. So what does non-operative treatment entail? And this is another debate between a above knee cast and a hinge brace. As we know from the AO's dictum, is that you want to preserve motion in intra-articular injuries. Most people agree on partial or non-weight bearing for 8 to 12 weeks. And this is a good paper published in the JOS in 2017, where they looked at 305 consecutive tibial plateau fractures. A significant number of them were treated non-operatively with inner range of motion brace with range of motion without weight bearing, with good to excellent results. And very importantly here, they looked at the one treated in a brace that did not have a good outcome. And in these cases, non-operative management was selected for patient factors, not for fracture displacement. In other words, it might be fractures that would have benefited from surgery, but the patient was too unwell or too old or too many comorbidities. So that basically means that a fracture that fulfills the criteria for non-operative treatment can be successfully treated in a adjustable range of motion brace compared to a plaster cast. So what is our surgical strategy for fixing things? Well, the first thing I think about is I try and identify the fracture pattern. I decide on what approach or approaches I'm going to use to address the fracture or the individual components of the fracture. I decide whether I need to visualize the joint, and if I need to, how will I do that? We can visualize the joint either through an open approach like a submeniscal arthrotomy. We can do that indirectly using the image intensifier. Sometimes you can do it arthroscopically, and then you need to address additional injuries. When it comes to the combination of arthroscopy with tibial plateau ORIF, it's something I was previously very enthusiastic about. In the vast majority of tibial plateau fractures, though, you're going to do an open approach, and it doesn't really add much to justify the extra difficulty and cost to use an arthroscopic visualization of your reduction. Unfortunately, because the joint is full of blood clots, it's never just simply quickly sticking a scope in. You can hardly see anything, and you need to first, debride some of the joint, wash it out before you can see anything. So for me, the one place where arthroscopic assisted management of a plateau fracture is useful in cases of a Schatzker 1, where there's a split with a depression, where you treat them percutaneously. As I said earlier, there's an incidence of up to 30% of associated meniscal injuries. When you fix a Schatzker 2, you do a submeniscal arthrotomy, and you can visualize the meniscus to see whether it needs to be fixated. If you're going to percutaneous clamp and put screws, and remember one of the junior consultants once losing a bet with Prof. Roche when he clamped the Schatzker 1, and he was about to put his screws in, and then because Steve insisted, Steve put a scope into the joint, and the meniscal tear was entrapped in the fracture. So you can also potentially identify this by just being very conscious on your reduction under the image intensifier. But in Schatzker 1 splits with displacement that you're going to percutaneous clamp, you must be aware that you might trap the meniscus, and after clamping and passing your guide wires of your cannulated screw, these are cases where it's useful to do an arthroscopy and to look at the reduction and make sure the meniscus is not entrapped, and also identify a possible associated meniscal tear that you can then repair arthroscopically. So when it comes to approaches, the one thing that's clear is that you need to be able to perform multiple different approaches to the knee if you want to successfully treat most tibial plateau fractures. So I would say if you want to be able to treat all tibial plateau fractures across the spectrum, you need to be familiar with the usual and unusual approaches to the knee, including posterior approaches. You need to be capable of performing arthroscopy in very select cases, and you also need to be comfortable putting up ring fixators for the fractures that's most appropriately treated with ring fixators. So fractures that you should know is the anterolateral, which is a standard workhorse for Schatzker 2s, which is the commonest fracture pattern. Posterior medial for bicondylar fractures, most in combination with an anterolateral approach. Posterior lateral approaches a lot less common than the others, but occasionally you need to be able to perform a posterior lateral approach and then a posterior approaches, or the variants thereof. Mri is very useful with good resources of the examples of the different approaches. So anterior lateral approach is something you're all familiar with. There's different ways to perform it. Important for me is I split the ITB. I don't do the sort of AO hockey stick approach, because that gives you a good soft tissue layer to close afterwards, and another layer between your plate and the skin. I do a submeniscal arthrotomy and use the fracture window to elevate the approach, to elevate the depression. When it comes to the posterior medial approach, so the posterior medial approach, this is mostly done for bicondylar fractures. With bicondylar fractures, you mostly have to also do an anterolateral approach. So this is best done with the patient supine, and you can use a variety of techniques to be able to do the posterior medial approach. You can either put the leg in a figure of 4 position. You can put the leg on you can elevate the leg, or if you have, some people do it over the end of the bed, or if they have a bed where the legs can fold down, you can also do this approach by folding the affected leg down. And this is just a landmark with your skin incision on the posterior edge. Now this is just, there's some confusion here occasionally between the posterior medial approach and the Logan approach. The Logan approach, which I'll show next, is a variation of or one of the variants of the direct posterior approach, where instead of going in the midline between the two heads of gastrocs, you go medial to the medial head of gastroc. But you are medial to the hamstring tendons. Here you are just lateral to the hamstring tendons. Here you are just medial to the hamstring tendons on the posterior border of the tibia. You can see here that you identify your pes, both the superior and the inferior border. This apex of the posterior medial fragment is always right underneath pes. So this approach was originally described by taking pes down. It's not necessary to take pes down. It's an important, for knee function, to have your hamstrings intact. And it's also nice for soft tissue cover over the plate. So you can mobilize the pes by developing this interval, both superior and inferior to your pes, and sliding your plate underneath. And there you can see the pes dissected free. Very important here is that you cannot do a submeniscal arthrotomy on the medial side like you can do on the lateral side, because then you cut your MCL. You can look into the joint very posterior. This is your deep MCL behind the borders, behind the border of the thick fibers of the deep MCL. You can look into the joint there, but you can never really visualize your reduction directly. Visualize your reduction indirectly by keying in the apex here and then using fluoroscopy. So here you can see pes, and then your apex of your fracture is usually right underneath pes, and you can slide your plate. You can slide your plate down there. There's two variants of the posterolateral approach. The posterolateral approach is not something performed commonly. It's originally mostly described in combination with a fibular osteotomy. And I have to say the last time that I performed it, I did it without a fibular osteotomy, which worked fine, like I show here in the middle picture. So I don't think it's necessary to do a fibular osteotomy. It's not often necessary. And the reason for that, if you read the paper on the column theory of tibial plateau fractures, that's very useful. So on the lateral side, the femoral condyle do not usually sublux with a posterolateral fragment. This happens on the medial side. So on the medial side, you need to often restore the joint stability by fixing that fraction. I've shown some examples later. On the lateral side, even if there's posterior comminution, the femoral condyle does not usually sublux with those posterior piece, and that's why it's seldom necessary to have posterior fixation on the lateral aspect of the tibial condyle. Although There are some exceptions, and occasionally it is necessary. This is the Logan offer approach that I referred to earlier. You can see here this is best performed with the patient prone, much more difficult to do with the patient supine. Also with the patient prone with a bolster under the thigh, because you need to sort of hyperextend the knee, often to reduce the fragment, but you need to be able to flex the knee to relax gastroc to visualize the joint. And you can see here, even though it's a posterior approach, your interval to the tibia is medial to the medial head of gastroc. And it's actually a very simple anatomical approach. That's easy to perform. So what's the options for fixation? Well, the screws and only, which we usually use for Schatzker 1 splits only, or with plating. Originally, all the Plateau plates were large fragment plates. All the modern sets were small fragment screws, as in 3-5 screws. And the reason for that is biomechanical evidence to show that you can more successfully raft depressed fragments or resist inferior displacement of loose fragments by rafting closer to the articular surface with small fragment plates. For the same reason that your fixation, your most proximal fixation, should be through your angular stable plate, and not like in the old AO technique where you put a compression screw above the plate. That is not so successful to resist depression of your elevated fragments. Lateral only versus dual plating. Show you when fixed angle anatomical locked plates came out, everyone thought that that's the solution for all tibial plateau fractures, and all bicondylar fractures were fixed with lateral only plates. Unfortunately, then over time there was a significant failure in certain cases with lateral placed only, and a slow move back to dual plating, specifically in select cases. And then circular external fixator with or without limited internal fixation. So what does the evidence say? Well, I think some of the strong evidence in plateau fractures is to avoid a single midline incision. In my junior years, starting to work in orthopedics, there was a big debate in bicondylar fractures whether this should be fixated to a single midline approach, because you can use the same midline approach in the future for knee replacement, because you had to then develop subcutaneous planes, both medially and laterally. This led to extremely high incidence of wound problems and should never be done. Even recently in private practice, I received a referral of a case where the surgeon performed a large midline approach for dual condylar plating in the early stages, and needless to say, the whole anterior skin bridge, whole anterior skin where the flap was developed completely broke down, and I'm not sure we're going to salvage that. It looks like that patient's heading for an amputation. When it comes to unilateral lock plates with a circular external fixator, there's insufficient evidence to recommend one over the other. We'll talk a little bit more about that later. When it comes to bicondylar plating, circular fixators versus dual plating been shown to have similar functional outcomes, the treatment, but lower complication rate in the frame cases. And in bicondylar fractures, like I said, even though there was initial move to lateral only plating, subsequently there's a move back to bicondylar plating because of loss of reduction in certain cases. And this is a paper that describes it very well, where they looked at 140 bicondylar tibial plateau fractures treated with plating, and about half of them, just under half, had unilateral locked plating only. And they looked at the ones that lost reduction on the medial side, and they concluded that medial subsidence occurred if there was a coronal fracture line. And that's very easy to understand. If you look at this axial of a CT, this is the typical fracture pattern where the fracture line on the medial side is either oblique or sometimes even dirocoronal. And if you fix this with a lateral based curved lock plate, you know, all your screws sort of converge on a narrow zone on the medial side, and you don't get very good fixation of this medial fragment. So this is why this case needs a separate, doesn't need a big locking plate on the medial side, but a small anti-glide plate on the medial aspect. So for the common fracture patterns, we use the Schatzker classification. My approach is for the Schatzker 1 to 4 cases. My first line treatment, if it needs operative intervention, is open reduction internal fixation with either just screws in the Schatzker 1 or plating in the other ones. My first line treatment for Schatzker 5 and 6 cases is circular external fixation with limited open reduction internal fixation with 1 or 2 screws, and it's only in select bicondylar fractures where I can convince myself that there's few large pieces where I can anatomically reconstruct the joint with a significant chance of success and low enough complication rate where I do bicondylar plating. So for Schatzker 1 and 2, as I said previously, non-operative if undisplaced or menial displaced. There's a high incidence of meniscal injuries, so you need to have a strategy to visualize the meniscus, either open when you do a submeniscal orthotomy, indirect with image intensifier, or occasionally arthroscopically. In Schatzker 5 and 6s, here I think specifically in the exam, you should always mention that you will consider temporary external fixation, specifically if the fracture is not out to length. In practice, like I said, the ones that you're going to plate, even if there's a small amount of shortening, I would X-fix out to length, because otherwise by the time you plate them 10 or 14 days down the line, the significant shortening is very difficult to get the length back. If you're going to treat it definitively with circular external fixation, you don't have to wait as long, number one, and number two, it's also easy to gradually get the length back, so you don't necessarily need to perform a X-fix. But the default should be for Schatzker 5 and 6 that you at least consider an X-fix. And then in certain fracture patterns, I would consider dual plating. The unusual fracture patterns, now like I said, this is important that you recognize these and also have a strategy on how to approach them. So these are all fracture dislocations or fracture subluxations of the knee. Almost all of them need external fixation, temporary external fixation. That are mostly high energy injuries. You should always mention that you would consider a CT angiogram or at least assessment for an associated vascular injury. And here you should be familiar with the non-standard approaches, posterior medial, direct posterior, and posterior lateral. Again, any tibial plateau fracture with a depression, you should ask yourself whether there's a need for a void filler. Again, it's important here to use the right terminology. Remember, when we talk about trauma cases where you have a defect that you need to avoid, we talk about a void filler and not necessarily bone graft, because you don't really want to augment healing. You just want to fill a defect. There's no evidence that autograft is better when it comes to being, when it comes to the need for a void filler. So bone graft substitutes have fewer complications, and you don't have to harvest autograft. When it comes to the synthetic grafts, calcium phosphate is superior to calcium sulfate in bone formation as a synthetic void filler. Now, this again is something that you have to decide on the ideal void filler where you end up working. In South Africa, We use allograft a lot, so we use partially demineralized bone, bone, as in bone croutons or bone chips, often for a void filler. This is not because it's superior to synthetic grafts. Synthetic grafts in South Africa is way more expensive than allograft, but this is very unique. And in most places, so if you look at developing world or first world literature, you'll see that they always talk about injectable void fillers. And this is not because it's superior to allograft. There's no, the two are the same. This is just because synthetic grafts in the rest of the world is much cheaper than allograft and more readily available. We just have a lot of dead people in South Africa. So here, allograft is cheaper than synthetic graft. Post-op management, early range of motion for sure. Prolonged immobilization is associated with a worse outcome. There's a very sort of topical debate at the moment about weight-bearing post-tibial plateau fractures and lots of lower limb fractures in general. This is a must-read. It's a letter to the editor by Alex Trumpeter, who's a trauma and limb recon surgeon in St George's in the UK, where he sort of summarizes evidence, biomechanical, theoretical, and some clinical evidence of why weight-bearing post-lower limb fracture fixation is beneficial. And he's published a series looking at tibial plateau fractures using the terminology the term weight bear as tolerated. So he's a big proponent for all fractures to be weight bear as tolerated, post-operatively showing no increased risk of displacement post-fixation, and some benefits to the patient post-tibial plateau fracture. So there's certainly no harm in careful weight-bearing post-tibial plateau fracture fixation. Complications, obviously sepsis is the big one, and you can avoid that by avoiding a single midline incision, appropriate timing of your surgery, but also very importantly, avoiding prolonged surgical time. As I mentioned earlier, it's a fracture that is associated with a relatively good prognosis when it comes to when you compare it to other intra-articular fractures, specifically in the lower limb looking at pilon fractures, and the overall incidence of post-traumatic end-stage OA post-plateau fractures quoted as 3%, minor OA 10% in the patient's lifetime, and the rate of conversion to knee replacement post-plateau fracture in 10 years at 7%, which is higher than the general population, but not that high compared to other intra-articular fractures. If you look at the outcome of plateau fractures, well, pure outcome is related to sepsis. That's quite obvious. Instability, and this is, as I said earlier, bony instability, so mostly due to not restoring the rim or the condylar width, so having unstable range of motion of the joint. Meniscectomy, so the meniscectomy is performance associated with a poorer outcome, and then mechanical axis deviation and fixation associated with poor outcome. And articular congruity did not correlate well with outcome in this paper, and that's why it's not our first aim as an indication for surgery in tibial plateau fractures. Okay, so before we look at some cases, any questions? Those have all been very quiet. Any questions? Let's see.
Maritz, I have a question. Hi, it's Ashley.
Yes, Ashley. Go for it.
In terms of weight bearing, when would you sort of start weight bearing? So sort of after 2 weeks after the sutures are out, or?
Yeah, so there's two interesting things with weight bearing, and that's what we tell patients, and that's what patients actually do. And there's lots of evidence to show that even when you tell someone to be weight bearing, that they actually do weight bear. They actually do weight bear as tolerated. So personally, especially most patients find it very difficult to be completely non-weight bearing. So I never treat anyone completely non-weight bearing. I normally say a minimum of touch weight bearing, because touch weight bearing at least then aid them at keeping their balance on the affected side. So I say touch weight bearing in a plateau fracture from the beginning. If it's a Schatzke-2 fracture with very stable fixation, after the first review in the clinic, as you said, 2 weeks, I tell the patient to be partial weight bearing and to put some weight on their leg as much as they can tolerate. If it's a bicondylar fracture with sort of tenuous fixation, you can be a little bit more careful. But I treat most bicondylar fractures with a circular external fixator, and they are fully weight bearing from the beginning.
Thank you.
Any other questions? Okay, so let's look at some clinical cases, and then maybe we can give some of the guys an opportunity to comment, especially for the seniors, practice with the exam coming up. Okay, this is the first case. This is a 41-year-old policeman stepped off a curb. Let's see who's on the call here. Niku, maybe you can switch on your camera if you're dressed, and
I am dressed.
Okay, and comment on the X-ray there. Just briefly, it doesn't have to be comprehensive. Just to quickly go over.
Oh, sorry, camera settings doesn't work now. So I've been presented with the APN lateral of the left knee. Most obvious pathology is looks like the Schatzke-2 tibial plateau. So it looks like there's a split depression, which is, as you said, is the most common fracture. What's the question? How do we manage this?
Yeah.
So I'll manage this according to Artcular's principles. It will be dictated by the soft tissue envelope, and yeah, once the soft tissue dictates, I would manage this with definitive intraoperative fixation with a medial base, lateral base plate.
Cool. So I just see here that I missed a question earlier. KL, who's KL?
It's Kim.
Oh, Kim, sorry. Okay, now so ask about the risk of compartment syndrome with arthroscopic assisted fixation. Yes, it is described, especially in bicondylar cases where there's disruption of the capsule, and you have to be careful, just like in multi-ligament knee injuries, to careful monitor your compartments for when you use fluid. Like I said, even though I initially tried it in a few cases, I didn't find it very beneficial. It's another sort of something that you need to set up in theater that takes time, and I didn't find it very beneficial. So the cases where I occasionally have used, where I felt it was useful, was Schatzke-1 cases, and here you don't normally have a big soft tissue disruption, and I don't think there's a very significant increase of having a compartment syndrome. Okay, so to get back to this case, Niku, good. So you mentioned all of that. There's your CT scan. Okay, so what would you do?
Okay, so oh goodness, sorry. So I can see on the axial plane that there's as we said on the X-ray, there's no medial component. It's only a laterally based fracture fragment. I think we will be able to manage this with the anterolateral approach only, splitting or yeah, exactly, lateral base plate.
Okay. Any comments on the post-operative fixation? Happy. Just remember the surgeon might be in the audience. Shouldn't be too hard.
It is beautifully done lateral base plate. I think we've restored the condylar width within almost normal parameters. And mechanical alignment seems to be good. There's no major interarticular step So I would be very happy with this post-operative result.
Okay, and then sort of a little bit disappointingly, this is a year down the line, but just of important note, and this is why I show this case, is intraoperatively this patient had a large complex lateral meniscal tear that wasn't repairable and needed a sort of partial, but most of his lateral meniscus had to be resected. So this is just important to show that you know, a meniscal injury like that that's not repairable, you know, carries a bad prognosis. And you can see even at a year down the line, the significant associated osteoarthritis. Okay, this is another injury. Does anyone know what a zorb ball is? Is this like giant soccer ball? And this guy actually had a video of himself. So it's this, I don't know who came up with that. So it's this huge round ball where you only have your limbs sticking out. So you basically have your legs sticking out from just above the knee, and then they do various things, roll down hills, or in this case they played football like that. And of course that's just the perfect you know, sort of large lever arm, and someone hit him from the side, and on the video you can see that his leg was in about 60 degrees of valgus at the time of impact. Okay, who else is here? Yapi. Yeah, Yapi.
Yes, Maritz, can you hear me?
Okay, yeah. So what's the diagnosis?
All right, so it's presented with the AP of a knee on the left-hand side, as well as a CT scan of a coronal slice through the sort of the same plane. So obvious pathology you can appreciate here is a large depression of your lateral plateau. I don't see there might be an undisplaced split running through there, but the joint with the widening of your plateau, not more than 1 centimeter, I would say. So for now, I would classify this as a Schatzke type 3. It was just a depression type.
Okay. Yeah, that I agree with you on this. On these images, you could maybe, sorry, you could maybe think that, but it was a, yeah, it is a split. It is a split depression.
So yeah, I would go with either a 3 or a 2. But I just want to see, just maybe get one more cut on CT if possible. So
one thing about like what people always say, it's about pattern recognition. So if you look at the CT scan, you can see that the condyle is probably more than 10 millimeters widened, and it's a 24-year-old. You know, a pure depression is a fracture pattern in osteoporotic bone, normally in older patients. So if you see a 24-year-old and it looks like this, I would just always call it a Schatzke 2, because you know, if you look at I don't have the axial here, but it is the lateral rim is sort of blown out. Okay, and treatment.
Right. So just from, but like you said, no axial view, I would still consider treating this patient operatively. First step would be to elevate, to do an anterolateral approach, like Nico described previously. So anterolateral approach, you elevate that little, or you create a small window, elevate that joint or that depressed part there at the bottom of your depression. Use a void filler, which would be bony croutons, and then do a lateral based plate for him.
It's interesting here. I did an MRI scan for the patient. Obviously here you can see the carnage here on the lateral side of the joint with the big depression, massive abnormal marrow signal, hyperintense marrow signal, which is bone bruising here. Anything else that you notice here?
Well, it looks like there's that meniscus on the lateral side appears to be into the fragment there, almost at the notch.
The meniscus completely inside the fracture. But also here you can see that the patient has an associated complete tear of his MCL. The reason why I MRI'd this patient, because he had a massive bruising on the medial side of his knee as well. But that just shows, and like we said in that paper, here, even though there was a complete MCL tear, didn't change the management of the patient, because, you know, we treated the MCL heel in a range of motion brace. And there's him with some oblique view 6 months post-op, showing a well-united plateau. And you would think that this is a worse injury than the one before, but he did absolutely brilliantly. And just because we were able to repair that lateral meniscus well, and his MCL healed just non-operatively in a brace.
Maritz, can I just ask, so intra-op, when you did your anterolateral approach, and when you get to that point, did you do a submeniscal meniscectomy or osteotomy to get into the joint and could visualize the meniscus in the fracture, or did you have to do it through fluoroscopy, or how did you manage?
No. So basically here, the meniscal rim was just sitting on the edge there. So I did a submeniscal arthrotomy where the periphery of the meniscus was attached. And then, which was interesting here, because normally then you see the sort of meniscus, the meniscal tear, which is normally, you know, on the quite peripheral on the meniscus. And in this case, the rest of the meniscus was way below in the hole, as you can see there. So, you know, I came into the knee sort of there, and on top of the meniscus, but we're able to put outside in horizontal mattress stitches there to repair the meniscus.
Thanks.
Okay, so this is another one. 56-year-old manual laborer fell from a height. Kirsty.
Yes, Maritz, I don't know if you can see me. Being presented here with an AP lateral X-ray of a, looks like a Schatzker 6 bicondylar with, yeah, no longer attached to the shaft. 56-year-old, high energy injury. I'd obviously manage them according to ATLS principles. It's high energy, so look for other axial loading injuries in the patient. And then obviously soft tissue is a major concern in this patient. So I would, I don't think this needs X-fix. The length and alignment look okay for me at the moment, but obviously I'd be guided by the soft tissues and whether he has major open wounds or blistering, and then potentially put an X-fix on.
Yeah, blisters is always mentioned. Massive blisters here. X-fix it if the soft tissue is not that severe. This is not grossly short, and then the one that you could consider not doing a X-fix, not doing a temporary X-fix.
Yeah, and then I would do a CT and then plan for surgical fixation. I think this is probably one of those that would benefit from a ring circular fixation and sort of limited internal fixation to catch those fragments across the joint.
Yeah. So the aim with the limited internal fixation is firstly to restore the condylar width to, you know, elevate the depression. So we know what we would normally do here is mini open, or, you know, open as big as needed to elevate that piece and put 1 or 2 subchondral screws to restore the condylar width and also keep that depression elevated. We're still going to put wires underneath, so we don't then need a void filler. And this is post, you can't see the 2 screws there because they're sort of just above the frame. You can see we've restored the condylar width. You can use any configuration of a circular external fixator. You can use an Elizarov, you know, certainly for metaphyseal fractures, because it's sometimes difficult intra-op to get your alignment absolutely perfect. I like using a hexapod, because then post-operatively, after completion of my first reduction, I obtain a long leg view, and because this is the most important thing for the patient's eventual prognosis, I make sure that the mechanical access pass through the middle of the joint. And here you can see at union and a good clinical outcome. This is another one. Ayik, are you on the call?
Yes, can you hear me?
Yes, I can hear you. What do you think?
Good.
47-year-old involved in an MVA.
So I'm being presented here with AP and lateral of the knee. So the obvious pathology here, I can see there is a fracture. For me, it bicondylar, but it may not. Looks like this is how it classified as this is an unusual fracture pattern. I can see there is a split. It looks like extending from the tibial eminence on the lateral side and extending down into the medial sides. And at the same time, there is a lateral fractures here. So I'm not sure.
Well, before I ask you, is this classifiable by the Schatzky classification?
No, it's not.
You don't think? Is it? I mean, maybe let me show you the CT scan there.
Oh, yeah. With the CT scan now, I would say this is a type 5 Schatzky.
Schatzky 5. Yeah, it's a Schatzky 5. It's a bicondylar fracture.
Bicondylar fracture, yeah.
Split and depression on the lateral side. Yeah, the actual depression, the split carries on very distal, which is a bit unusual. And then there's the typical posterior medial fracture on the medial side. How would you treat this?
So I would treat this according to ATLS principles. I would be dictated here by the soft tissue. So it depends on how the soft tissue. Otherwise, I would need to approach these patients by the 2 incisions, lateral, anterolateral base incisions, and posterior posterior medial incision as well. So I would first approach the lateral side and try so the lateral base plates with a small medial plate.
Which side do you fix first?
I fix the medial side first.
Yeah, good. Okay, that's important that you restore the height on the medial side.
On the medial side.
And fix it from lateral, but then important from medial that you don't have bicondylar screws on the top, because you still need to be match the height on the lateral side. So this fracture compared to the other one is not nearly as comminuted. You know, it's a younger patient, and there's a single big piece on the medial side, and you know, I feel that I can predictably here fix it with plate fixation without a very high risk of soft tissue complications. And this is the post-op X-ray. Okay, let's see who.
Maritz, it's Bayanda.
Yes, Bayanda.
Can I ask a question?
Yeah, of course, yeah. Go for it.
Can you hear me properly? There's no echo.
No, you can hear you well.
Okay. That previous case, I thought it was a little bit shortened. Would it be correct to span it first?
You mean this one?
No, the one Ayik just answered.
Oh, the one that Ayik just answered. Yeah, for sure. This is the and I do, to be honest, we must look for X-fix holes there. I can't. I agree with you. I think if I saw this X-ray initially, and I was planning to plate it as my definitive management, I would definitely X-fix it, and I think that should always be your default. And then in select cases where there's no shortening, plate it. I cannot actually, this case is a while ago, and I can't actually recall. It doesn't look on the CT like there's an X-fix, but this would be unusual. The only thing I can think of that there wasn't a significant soft tissue injury, and we could get there fairly soon. But I agree with you, the default should be external fixation in a case like that with shortening, definitely.
All right, thank you.
Okay. Who else is here? So vicious out of action. Who else is here from next? Chichi. What do you think about this case?
Yes, Maritz. Okay, I'm presented with 2 X-ray views, a lateral and an AP of the left knee. But it seems like it's not a typical tibial plateau fracture that we see. I think this falls probably under the Holland-Moore classification. But looking just on the AP view, I think it seems there's a depression. There's a depression of in the middle of the tibial plateau, probably with a flipped fragment with the articular surface facing either downwards and looking on the lateral view, but there's no condylar widening that I can appreciate, maybe slightly, but I don't see any, there might be a slight varus deformity that I can appreciate from there, but this might be either more like a capsular avulsion type of injury in this AP view. And just looking on the lateral, it looks like there's a split that is more in the like sagittal plane, but starting from either anterior superior going to posterior.
Where do you think is the fracture? Do you think this is a coronal or a sagittal fracture line here?
I think so. I think it's a coronal fracture
yeah.
line.
Okay.
Yeah,
so where do you think this displacement that you can see on the cortex, where is that?
I think it's on the medial side.
Yeah, it's on the medial
I think it's
side.
the medial side, yeah.
So this is if you don't necessarily have to know the whole polymer classification, but the principle is that this is a medial condylar fracture that exits lateral to the intercondylar eminence. And the important thing here, when you have a Schatzke fracture, you have your lateral rim that's sort of blown out and displaced, but most of your tibia, your whole medial tibia, and everything except for that lateral rim has maintained the normal relation with the femur. This is a fracture subluxation of, in the more extreme form, fracture dislocation of the knee, because it's only this part of the tibia that still has its normal relation to the knee, to the femoral condyle with the MCL. The whole rest of it's displaced, and you can see it better on CT. So there's the fragment that you should identify, and here you can see it. And it can look fairly innocuous on the X-ray, but it's important here that you should recognize that this must always be treated not operatively. And you can see here that the femoral condyle is subluxed with this piece. Okay, and if you try and treat this non-operatively, the patient will have a very bad result. There's a little bit of a depression, but it's right across on the posterior lateral part, and that's also important to restore. The important thing is to restore this back to where it should be. And this is where you need a posterior approach, and then the nice variant of the posterior approach that makes this a lot easier is the Logan-Hoffer approach. So this is a posterior approach of Logan-Hoffer with a posterior base plate.
Okay.
And there you can see the patients post-operatively doing well. This is another recent case. Another similar type injury. Let's see who else is here. Who else is with Chichi? Mike?
Emirates.
Yes, what do you think?
So yeah, looking at the AP and the lateral, the knee, obviously post-operatively, I'm guessing. I don't know when the surgery was done.
Yeah, so this is like a lot of our patients, this is a frequent flyer. He's a motorcyclist, years ago had a multi-ligament knee injury, and now there's a polytrauma with a new injury to his knee. But the fixation that's in there is from a previous multi-ligament knee reconstruction.
So it looks like he had an ACL repair. There's from a previous anchor, and then fixation of his, I don't know what that was, with 2 screws. So currently, it looks like he also has what I would describe as a similar Holland-Moore type 1 based on these X-rays. I'd like to get a CT. It just looks like a coronal split of the condyle. I can't see it coming across from medial to lateral and keeping with a Holland-Moore 2, but I would get some CT scan to confirm it. Once again, I'm concerned about the subluxation or dislocation, high energy injury for this patient. Yeah, so looking at the CT with 3D recon, sure. So it actually is a little bit more complex than I'd like to think. There is like a Holland-Moore type 2 variant that goes from the medial across to the lateral condyle, but also an extension fracture down into the metaphysis that you can just see on that right side of view. So it's a difficult fracture to fully classify, but it's high energy. and needs to be addressed surgically. So it manages according to ATLS principles. I think for this patient, there could be a case made for a similar posterior approach just to get that fragment up, and anti-glide principles just to restore the height, and then maybe a combination of subchondral screws and potentially even a hexagon external fixator.
See, the important thing is to realize here that you can see the femoral condyle is sublux with this piece. And so this is important, that this needs to be restored from a posterior approach, similar to that other one. And that's why I showed this case, because I think it's Francis here on the call. This is a recent case. You can see this is also interesting because it had this like split that extend all the way down. And there was also a depression across on the lateral side, but you can see the lateral rim is intact here. So that, you know, wasn't such a priority. And there's also right posterior to restore. So a single posterior based plate, and then a separate just interfragmentary fixation from the front.
That extension threw me off to classify, but I suppose
yeah, I think, you know, like there's always exceptions. And you know, you could say that this is a Schatzker 6 because there was, you know, because that extension down, but I think it behaved more like a fracture subluxation of the knee. And then once you're familiar with this approach, you've done it a few times, you can ask Francis. Francis did this case, and it's not as difficult as it seems. One last case, and just to show you that occasionally, this is how one receives your referrals nowadays, by a WhatsApp video of a bicondylar, similar Holland-Moore type fracture subluxation on the knee. But you can see here that there's a significant lateral also split and depression in this case. So this is a bicondylar fracture with a lateral split depression, but where the medial fracture is very coronal, and posterior also needs a posterior plate. So this is what I usually try and avoid, but occasionally you have to do it. So this patient had a posterior Lobenhofer approach and fixation, first of the patient prone, and then turning the patient around, and then a anterolateral approach with an elevation and a lateral base plate. Any questions? So we've still got to run through the rest of the shaft. Yeah.
Just a quick one. Do you know of any literature looking at, I know you spoke about MRIs now, and the fact that you probably don't need them for standard plateaus. Are there any MRI series in Holland-Moore type classification needs? Because they are more associated with subluxation / dislocations of the knees. And for your standard Holland-Moore, would you advocate the MRI?
I don't think so. You know, I think, look, get back to the Holland-Moore classification. It depends whether there's like a multi-ligament injury.
Because I know like 3s and 4s, you get revulsions and all that. That
yes.
Would be fine, but...
So these 3s, you know, 3s and 4s, these are the sort of associated fractures that you sometimes see with multi-ligament knee injuries. So it's a tiny little rim avulsion or a depression with a significant soft tissue injury of the knee. And those are the cases that need an MRI scan, because for me, even though technically there's a fracture of the tibial plateau fracture of the tibial plateau, it's more a multi-ligament knee with an associated minor fracture. So I'd say
those are rare.
Holland-Moore 3 and 4.
Okay.
No, not for a standard 1 or 2, because here normally when you restore bony congruity, that's adequate. Occasionally, like I said, in the minority of cases, and this is usually type 3s, where there's a, you know, sort of a piece just big enough that needs to be directly fixed, would you do combination of fracture fixation and ligament reconstruction. So I would say for the 3s and 4s, this is more multi-ligament injury with an associated small fracture.
Okay, cool, thanks.
Okay, so I'm going to stop there. Any questions on the plateau fractures? Okay, no, it's already a little bit
I've got a question.
Sorry, yeah, go for it.
I just want to, I'm just asking more on the technical side of it, because I haven't seen or myself been involved in treatment of a plateau with a hexapod frame. So once you put in your subcondylar screws, you close the joint down, say in a bicondylar, you put up, and then you put the frame on. And I got from the previous pictures, you try and reduce it as anatomically as possible, but you still tweak it. Do you still have to tweak to get it the alignment post-op, or
yeah, for sure. So I call it a social reduction. Pull on it and get it as reduced as you can intra-op, but then run a program post-operatively, and after that program, once the patient's mobile, get a long leg view, normally in the first clinic visit, to make sure that the alignment is perfect. It's absolutely fine doing this with Elizarov as well. When it comes to treating complex trauma with circular fixation, the biomechanics of a hexapod is more designed for deformity correction, and the biomechanics is certainly not very good for shaft fracture. So I never, except if it's a chronic fracture where you want to gradually reduce it to the soft tissue, or you want to do augmented frame-assisted closure of soft tissue. Never put on a hexapod for a mid-shaft fracture, but for metaphyseal fracture, healing here is normally not a problem, and it's just much easier to put a hexapod on and get your alignment afterwards. But there's absolutely nothing wrong with doing it with an Elizarov. I just like having the adjustability of a hexapod for metaphyseal fractures. So pilons and plateaus I normally do with an hexapod. Shaft fractures I do with an Elizarov.
Right. So yeah, that was my next question: do you run a program or not? So yeah. So
yes,
thanks.
I do. If the alignment's not perfect, then I do a program. For it mostly is the case. I don't spend too much time in theatre. I give sort of a little bit of a pull, social reduction, and then when Amar just asked here, it's okay to put a proximal half pin. Yes, so it depends, on the fracture configuration. Often, once you've put in a very comminuted fracture, there's no place to put a half pin. Or you use normal wires, but sometimes you've restored your sort of proximal box with the two screws, and if there is a large enough piece, then I sometimes use half pins as well. So I use a combination of mostly wires and occasionally a half pin, depending on the fracture configuration in the proximal part of the fracture.
All right, thanks.
Okay.
Maritz, hi Maritz, sorry.
Yes.
Just that previous injury that you showed with the guy that had the hardware in, that had the ACL, was that a Hollandware type 3 that they fixed with the washer and the screws, you think, from the lateral side, those two screws here, the one that broke?
It could be that was a rim fracture that was fixed like that. That one screw looked like it had a soft tissue washer on it, the old plastic soft tissue washer. So that was possibly part of a posterior lateral corner fixation, sort of an old way of fixing it rather than anchors with a screw with a soft tissue washer. So it's difficult to know.
Okay, cool, thanks.
Okay, happy. So let's quickly look at the controversy with tibial fractures. So I know it's already quite late. I'll go through it quickly. So tibial shaft fractures, like I said, the basics you guys should know. Just going over some of the current controversies. And this is what we'll look at. We'll just look at some background, and then internal versus external fixation of open fractures, fixation for distal third tibial fractures, bifocal tibial fractures, and the management of the mangled extremity. So just a little bit of history on nailing, and the first sort of nail described was intramedullary wooden pegs in the 1500s. Sort of nailing has come a long way. In the 1940s, the Kunschner nail was described, which is really the predecessor of what we now know as intramedullary nails. Initially, the Kunschner nail was done percutaneously and the first 105 cases was reported in 1947, and they said it spread through Europe, and they call it medullary nail euphoria because everyone was so impressed with the outcome. And for those that don't know it, in the history, orthopedics have made the front page of the Time magazine twice. So once was for what's called more recently, what was called the operation of the century, which was a hip replacement. And then the first time that orthopedics made the front page of the Time magazine was in 1945, and this was when an American soldier that fought in World War was injured. He was shot in Europe, and he was treated in Germany, and he came back to America with an intramedullary nail in his femur. And they commented in the Time magazine that this was a daring operation, and the American surgeons was amazed at the outcome of the surgery. So initially it was done percutaneously with great difficulty. Also when X-rays was available, it was very high doses, and there were lots of radiation associated complications for surgeons treating patients, and that's why the retrograde technique became more popular after the invention of antibiotics, because before antibiotics that was again associated with a very high infection rate. In the 50s, they expanded nails to using reaming that allowed larger diameter nails and higher union rates. The 60s, plating was a bit more in favor. In the 70s, there was a renewed interest in nailing. And the first AO series of interlocking nails demonstrated a 98% union rate for reamed intramedullary femur nails. And the reason why I really give this background is to show you that it's only really in the 90s that nailing extended to the tibia, because nailing of the tibia shaft is not as straightforward as nailing the femur. So the modern nails that we use is the so-called 4th generation nails, where there's more locking options. We've got threaded holes with angular stable screws, and this have allowed us to extend the indications in the tibia to proximal and distal metaphyseal fractures. So one of the controversies in the treatment of tibial shaft fractures is internal versus external fixation and open fractures. And you might say now, well, this is not a controversy. We nail all open fractures, and it is the case. But fairly recently in our department, when I was a registrar, it was absolutely not allowed to treat any, even a grade 1 open fracture with a nail. And we sort of gradually migrated to a much more aggressive approach with good results. And we can now say, like from our host study, where we have very good data, is our infection rate in open tibial fractures treating with a nail is 7%, which is really very low, which really justifies our approach. So just important that the most important thing in the prevention of infection following open fractures is early antibiotics. Time to debridement is not so important, especially within the first 24 hours, and it's only really after 24 hours that the infection rate starts going up, except for highly contaminated fractures. And the aim is really to close soft tissues as soon as possible. This is again another previous historic approach where all open fractures was left open at the first loop and then closed at the second loop. And Godino's landmark paper is already quite old, in 1986, showed a significant increase in infection rate if open fracture was not closed within 72 hours. So we close all fractures except for the ones that are grossly contaminated, or of course not closable. When it comes to mode of fixation in open fractures, intramedullary nail with external fixator, and this is to justify our approach, that there's no difference in the infection rate or the union rate or the time to union. There are fewer cases of malalignment with intramedullary nailing and fewer secondary surgeries with intramedullary nailing, and also a shorter time to weight bearing. So the next sort of even more aggressive approach beyond just simply nailing lower level open fractures is the so-called fix and flap approach, even though that's something that sort of recently became popular, specifically in the UK. It's nothing new. It was first described in 2001. And initially, importantly, it was described as performing open reduction, internal fixation and open fractures, and getting soft tissue cover within 72 hours. Although the newer evidence shows that the soft tissue cover should be in the same sitting. So that's why for us, the indications for fix and flap approach is really type A hosts, appropriate initial fracture management. This means a fracture that was timeously received antibiotics and a sterile dressing or initial wash out. And then also very important, where you can have reliable soft tissue cover. We're not going to put a nail in if it's a junior plastic surgeon doing his first free flap, or a plastic surgeon doing his first free flap. You want to make sure that it's going to be reliable soft tissue cover. And most importantly, you need to agree with the plastic surgeon when you put the patient at the table is that they will perform the flap in the same sitting. So you never want to send the patient to the ward with fracture fixation without soft tissue cover, even though it is described in the literature to get the soft tissue cover in up to 72 hours after the fracture fixation. And again, mostly nails, less enthusiastic about plating and doing a flap, just because the nailing fixation is so much more biological than with plating of fractures. And this is just an example from Quitterskier, a case you can see from that sort of biplanar configuration of the JEDEX. I think the patient came from Somerset with a grade 3 Mri open tibia that's then converted to a nail and a propellered fasciocutaneous flap in the same sitting that Chris did, with a good result afterwards. Something to go over quickly is the fixation in distal third tibia fractures. Again, there's a historic debate. So with distal third tibial fractures, like I always said, when you see a transverse fracture of a femoral shaft in a young patient, high energy, you immediately look at the neck of the femur. Same in a distal third tibia fracture, you always need to look for extension into the ankle mortise because it's present in up to a quarter of cases. Historically, nailing at a very high complication rate, and that's why plating is advocated, or other treatment modalities like circular fixation. Fourth generation nailing has vastly improved the outcomes of nailing of distal tibia fractures, and we're now very aggressive to basically nail all the fractures that we can. So what's the problem with nailing versus plating? Well, there's no difference in union, but there's more cases of malalignment with nailing and more wound problems with plating. So I would just say that complications of nailing can be avoided with good technique, whereas the complications of plating, you still get sometimes even with good technique, and that's why I am more of a fan of nailing of distal tibia fractures. So the treatment options, of course, not just nail and plate, can also be circular external fixation. The UK Fixit trial is an important study, was published a couple of years ago by Matt Costa, a big multi-center study where they randomized patients to a nail versus a plate, and they followed them up for 12 months. Importantly, there were no difference between the two groups at 12 months. However, the nailing group were full weight bearing at 6 weeks, and they had significantly better function prior to a year, like in 3 and 6 months, and they also had fewer secondary operations than that plating group. This is for removal and so forth. So what to avoid with nailing? Well, you need to avoid malreduction. And how do you avoid it? You need to avoid that by reducing the fracture prior to nailing. And there's a variety of techniques that can be used. You can use a simple percutaneous reduction, like with a reduction forceps. You can use blocking screws, or you can use temporary frame or external fixation, or femoral distractor assisted reduction of the distal tibial fracture. But the important thing is that you need to have your fracture reduced before you insert the nail. It's not like a femur that will reduce as you insert the nail. And this is an example of a good fixation. You can see that there's a hole there where a temporary blocking wire was used to redirect the fragment one insertion with insertion of the nail. This is another thing that's another sort of newer term that's topical, which is called bifocal tibia fracture. When we talk about segmental fractures, we refer to fractures, 2 fractures of the shaft. Bifocal fractures refer to fracture of the 2 separate fractures in the tibia, or 2 separate fragments in a limb segment. So this is either a plateau fracture with a shaft fracture, or a shaft fracture with a pilon fracture, or a plateau and a pilon on the same leg. Again, this is something that's historically very complex injuries to treat, and with 4th generation nailing, it's also too safe to nail these, and this is where we refer to the so-called fix and nail technique. As I said, there's 3 groups: plateaus and pilons. These are probably the easiest ones, to make decisions on the treatment. I'm not saying easy to treat, because you basically, the fractures are far apart. You just treat the plateau on merit and treat the pilon on merit. The diaphyseal fracture combination with proximal or distal fracture is a little bit more difficult, because mostly for the diaphyseal fracture, your first line treatment would be intramedullary nailing, and that interferes with the treatment of your plateau fracture or ankle pilon fracture. So this is an example of a plateau shaft combination. You can see here from the CT, this is a sort of Holland-Moore lateral condylar fracture that exits medial to the intercondylar eminence in combination with a shaft fracture. These combinations are usually young patients, very high energy injuries with high incidence of soft tissue problems. So you should be alert to that. And this is just a paper that sort of sequentially shows the technique of how you can treat it with a combination of open reduction, internal fixation, and nailing. And you do this, and I obviously say you need to CT scan first to plan. You do your plating first with minimal fixation. If you look at this axial, you mostly put your fixation posterior to the entry point first, and some maybe unicortical screws in the shaft. Then you do your nail, and then you complete your fixation to this. You can look here, you can see fixation posterior to the nail, unicortical screws in the shaft, and then you can swap the bicortical screws and complete your fixation after you've done your entry, after you've inserted your nail. And you can see here 50 patients of combination plateau and intramedullary fractures, and they were able to do a combination of plating and nailing in 34, which is a high percentage. Of course, there's other options like limited internal fixation and circular external fixation, but they can definitely be safely nailed with the appropriate technique. And this is that same example. You can see a proximal shaft fracture, proximal plateau orif, and then with nailing of the shaft fracture. This is an example of a combination of a pilon fracture with a segmental tibial shaft. Again, there's multiple different ways to treat it, but it can safely be nailed, providing that you address the distal displaced intra-articular component first. Of course, I normally look at it whether the intra-articular component is a simple or a complex fracture. If it's a simple single fracture line, it's these are the ones that you can normally treat with fixation of that first. You restore the box, and then you can do intramedullary nailing. There's always a question with these fractures, especially the combination of shaft and pilon fractures, whether the fibula should be plated. So it's important to look here at look at the relations between your distal tibia and your fibula. Look at talocrural angle, and if the patients maintain the normal relations between the distal tibia and fibula, then you don't have to address the fibular fracture, even if the fibular fracture is very distal, because there's often an increased complication rate with these high energy injuries if you add fibular plating as well. Occasionally, though, there's a ligamentous injury to the distal tibiofibular ligaments, and that's where the normal relation between the distal tibia and the fibula is not normal, and then you need to consider fibular plating up to length. So here you can see, firstly, the pilon component, which is a simple coronal split, is fixated percutaneously with 2 screws. This basically restores the distal box, and that's then treated with a suprapatellar intramedullary nail. As is often the case with these bicondylar, bifocal or segmental fractures, here you can see that the distal shaft fracture and the pilon united uneventfully, but the patient developed a non-union of the proximal fracture, and that was then treated with an exchange nailing and fibular osteotomy before the patient united. Another common fracture pattern is the combination of a diaphyseal fracture and a non-contiguous medial malleolar fracture. This is quite common. We see it on a fairly regular basis, and this can be treated with intramedullary nailing and separate fixation of the medial malleolar fragment. Any questions around that? Bifocal tibia fractures, or any of the controversies in treatment of tibia fractures?
Maritz, can you hear me?
Yes, I can hear you, Pravesh. Do you recognize your X-ray there?
Yes.
Okay.
I have a question. In a closed tibia fracture with acute compartment syndrome, how would you manage it in theater? I mean, do you sort of do the fasciotomy and then backslab and come in 72 hours and do the nail and skin graft, or do you put the X-fix on, or do you nail and send the patient to the ward with fasciotomy wounds? So,
look, I think it's as you say, it's a very controversial topic. I think you should be very cautious in nailing a patient with an established compartment syndrome where you need to do fasciotomies. In real life and in the exam, and always the safest answer and the safest in when the patient has an established compartment syndrome that needs fasciotomy, it's safer to X-fix the patient, because you don't further want to increase compartmental pressures by inserting a nail, and you don't want the patient to go to the ward with large fasciotomy wounds and an internal nail. So you need to do a very simple X-fix. I would say as well, when you do a fasciotomy, very seldom should you not stabilize the leg, because that's important to limit ongoing bleeding and increased compartment pressure. So once you do fasciotomies, you should always stabilize the fracture, and the default should be an external fixator.
Okay, thank you.
And you should obviously just appropriately adapt your configuration to do mostly anterior based pins, because to avoid your wounds for your fasciotomies. Okay, yeah. If we just briefly touch on the mangled extremity. Any other questions? Sorry. So this is another very difficult question in orthopedics, is when you confronted with a mangled extremity, and when should one attempt limb salvage to give an acceptable result in an acceptable time frame to the patient, or when should you proceed to an amputation? It is very difficult to make that decision, and there's various things that you need to take into consideration. Amputation also is not the end of one's life. This is a picture of probably one of my most thankful patients. She was born with fibula and amelia. She had something like 28 or 30 operations through her lifetime to try and restore a leg length, an ankle, and all of it. And she eventually opted to have an amputation as an adult. And this is a picture of her doing a swim to Robben Island with a prosthesis. So one can have very good function after the amputation. And that's why I don't really like the terminology of limb salvage versus amputation. I give this lecture at the AO Masters course that's historically called limb salvage versus amputation, and I like to call it limb salvage versus prosthetic limb reconstruction, because amputation is really just the first step in prosthetic limb reconstruction. So you need to decide whether limb salvage is appropriate versus prosthetic limb reconstruction. So it's limb reconstruction versus prosthetic limb reconstruction. And our aim is to give the patient the best possible function in the shortest possible time frame with the resources available at the place where we work. So the initial decision making can be quite difficult. Sometimes it's obvious, like the picture there on the right, but unfortunately most of the time it can be quite difficult. There's various scoring systems that's supposed to help guide us. The MES score is the best known one. Unfortunately, the MES score is not very good at predicting successful limb reconstruction. It predicts short-term limb survival by basically just predicting, whether you'll be able to salvage the limb from a sort of blood supply point of view. The Ganga hospital scoring system is more useful. We'll discuss that shortly now. And there's also some trauma prediction models available online, similar to prediction models for metastatic bone disease, where you can enter some parameters. But once again, it's quite good at predicting short-term limb survival, but not long-term successful limb reconstruction. Why I like the Ganga scoring system is because they looked at a much bigger patient cohort than the MES score, and they also included the late amputation. So in other words, these are the patients where they initially managed to salvage the limb, but the patients had an eventual later amputation for unsuccessful limb reconstruction. So they were initially able to salvage the limb, but they weren't able to get on top of the infection or manage to get all the fractures to unite, and the patient still needed an amputation. All of you should be familiar with this. It's a scoring system where you give a score out of 5 for 3 main categories: the covering structures, so the skin and the fascia; the skeletal structures, this is the bone; the functional tissue, this is the nerve and muscle; and then there's some comorbid conditions where you can add a modifier of 2. And in cases of 14 and more, you should consider an amputation. And they showed in their series that score of 17 and more correlated 100% with eventual limb loss, and you should consider an amputation initially. So this is the scoring system. If you don't have the paper, you can let me know and I'll forward it to you. But as you can see here, the top scores in covering structure is circumferential wound loss. In skeletal structures, is bone loss of more than 4 centimeters, and functional unit is loss of 2 or more compartments. Modifiers: age, prolonged delay to presentation, severe contamination, diabetes, polytrauma, hypertension, and other major injuries on the same limb. There's a couple of myths that should be dispelled when it comes to the initial decision making regarding amputation. This is from the LEAP study group. This is always taught as a fact that any case with absent plantar sensation should have an amputation. Unfortunately, this study group showed that initial absent plantar sensation recover in up to 50% of cases. So initial absent plantar sensation should not be an absolute indication for limb salvage, and should again be just something that's taken into consideration with all the other factors. The other myth is that patients do better when they have an early amputation. This is a South African paper by Frans Werkels that just showed that using some psychometric analysis, that patients with delayed amputation had as good functional and psychological results. And often for some patients, they are more happier with their decision when they felt that everything was done. So it's definitely not wrong to delay initial amputation. Patients can have similar eventual functional outcome with the amputation, whether the amputation is performed early or late. So what do we take into consideration? Well, firstly, the degree of injury, and here a scoring system is useful. Probably one of the biggest use of the Ganga scoring system, it just helps you to systematically think of all the aspects of the injury, and also to document the score to show that you consulted it to try and make your decision in a scientific way. You need to take into consideration the expertise available where you work in orthopedics and plastic. You need to take into account the timeline of a reconstruction. In some cases, the timeline of limb reconstruction might be a year or 2 years, and that might not be acceptable for the patient. Also need to look at the amputation options. We're sort of much more amenable to consider amputation if you can do a below knee than when you have to do a through knee or above knee, because the functional outcome of an above knee amputation is not as good as a below knee amputation. And then you also need to take into consideration the patient's access to prosthetic services. So what do you need from an orthopedic point of view? Well, you need the expertise to manage bone defects. From a plastic point of view, you need the expertise to manage soft tissue defects, to successfully salvage these mangled extremities. This is an interesting paper where they looked at two countries, one developing and one developed, and they looked at the factors that predicted better quality of life in amputees. And the two things that came up top in both countries was access to a prosthesis or use of a prosthesis and employment status. So amputees are generally have a higher quality of life if they still employed and if they have access to it, if they have use of a prosthesis. There's very little published about amputees or the available of prosthetics in Africa. This is a Nigerian paper, and I think if you look overall in South Africa, it won't be much different. That in Nigeria, this is looked at the National Health System, they look at 87 amputees, and only 13 or 16% of patients received prosthetics. In other words, if there's no access to prosthesis, sometimes any limb is better than nothing. So one should consider more leaning towards limb reconstruction than amputation if the patient's not going to have, if at all possible, if the patient is not going to have access to a prosthesis in the future. If you look at the cost of limb salvage, well, in the short term, limb salvage is often more expensive, and that's because of the expensive, treatment of plastics and frames and orthopedic surgery. But in the long run, this is offset by the high cost of prosthesis. So always in the long run, limb reconstruction is cheaper than prosthetic limb reconstruction. And then the last thing to take into consideration is the level of the amputation. As I said, below knee amputation function do much better than above knee amputation. The important thing is here, when you decide where to amputate, it's important to discuss it with your prosthetic service. The main debate is always between a through knee amputation and above knee amputation. A through knee is a very good amputation, you have an in-bearing stump, but when it comes to sort of cheap prosthesis, the prosthetic knee is quite bulky, and that can lead to a differential knee height. More high-end prostheses have a very narrow or very thin knee, and it's not such a big issue. But the important thing is, when you have an opportunity, you should always discuss it with the prosthetic service to decide where to perform the amputation. And whichever level you are going to perform the amputation at, it needs to be well done. So basically, the take-home message is that your decisions should be individualized, and it should be based on the degree of injury with the use of scoring system. It should depends on the expertise you available at where you work in limb salvage technique. That's not just orthopedics, it's plastics as well. The timeline of the proposed reconstruction, the different amputation options, and also whether the patient will, in the near and far future, have access to a prosthetic service. Thank you very much. Okay, guys, that was a mouthful. A lot to go through. Is there any questions around mangled extremity or anything else that we discussed?